fall apart, you'll have to fall back on research. You know, if there's no clinical jobs, well, you'll at least have you'll have some market. You have a skill which is marketable. You understand the medical world, that has value. Maybe you'll have to do it just research, but I don't think it's going to happen.
And the area that you bring up is one of the issues we had as we were moving our primary healthcare program to the master's level, and certainly what did we expect of this provider? Certainly clinical practice was the key thing. So most of the NP programs are course-based, where the NPs may be involved as PIs on research, they may be involved in research teams, or they may be definitely able to appraise and utilize research. So I don't see why PAs couldn't do the same thing in a health team if there's research going on, to be an active member of research that's happening in their area.
PAs in the province at the current time, it's an undergraduate degree. In the States, it's typically a master's degree, Manitoba master's. It is possible to take our bachelor's degree and do a master's completion. That is a possibility. You might well ask, well, why is it a bachelor's degree? It's very simple. That's what the government wanted to pay for. Government calls the shots. They said to McMaster, "We think. How do you think about starting a bachelor's program in MBA studies?" And the program says, the university says, "Oh, it sounds like a good idea. Where's your money?" Right? It's not complicated. People think why is it this way? It's just so. It's a government decision. Why did they make that decision? I suspect it's got to do with money. It's less money than a master's program. Is it going to change to a master's program? Hard to imagine it won't, right? I mean, given the fact that's what's happened over the 40 years in the United States. 15 years ago, with most people just have bachelor's degrees. Now it's a master's degree. So I think that'll happen, but things change over time.
40 years.
All right, so are there any other questions from the audience? Anything?
So would it be fair to say that the patient wouldn't be able to differentiate between a PA and a nurse practitioner, and that the main difference, I guess, would be to the physician is that the difference between PA and NP is that a PA gets pools delegated to them and is independent?
I think it would be fair to say that the patient would never know the difference. What happens behind the scenes might occur differently in terms of the delegation, but the bottom line will always be the funding structure.
And in all of these healthcare professions, the quality of the provision of care is the paramount thing. That's the reason we're here. That's what everybody's is there. So even if you're seen by the clinical clerk, it doesn't stop there. Everybody has a sense of ongoing responsibility till the patient is looked after to the best of the ability of the system and the people involved. I think that's fair.
All right, question at the back?
Could you talk a little bit about the role of an NP in starting their own practice, and more so how it differs from, say, like a family physician?
Other than the NP-led clinics, I don't know of an NP who's actually started their own practice. As much as we've said the NP has the autonomous ability to diagnose, prescribe, treat, etc. under legislation, the truth is, even with Bill 179, the drug and lab list is still confined in many ways. That collaboration has to occur between the NP and the physician still. It is not totally autonomous in terms of the decision making. And CT scans are a prime example. For instance, an NP can't order a CT scan. It would need to go through the physician to be done. The NP can't make a referral from in primary healthcare to a specialist because of funding structures.
So I can write a referral note, but until it has the physician's billing code, the specialist can't bill for that new referral.
So that's
So
the
it
billing.
becomes-
That's this distortion by the
Yeah.
billing numbers that the consultant won't see the patient unless it's referred by a doctor. And you know why? He actually can see the patient.
Oh, yeah,
He
that's
can,
right.
but you only get half as much money. So that's the answer. So,
So I will do a referral letter, we stamp the doc, whoever the patient is rostered to, stamp that one off so that they will get the money.
I think
Which
it's
is
gonna be.
fair, I think the specialists should get the money for what they're owed. I think it's unfair that just because I write the same letter,
You
that
should
it's a
get, I should
different
get paid half. I think it's gonna be very interesting to see what happens with the nurse practitioner-led clinics. I think, you know, I don't know much about them, I guess. Does anybody know much about them? Is there a lot of information about them?
Alba, for the most part, these are patients that truly are not rostered with anybody, have not had a family physician at all. And underserved rural areas that are having problems with access, etc. So, you know, it was Marilyn Butcher and Roberta Hill that really made this offer about the nurse practitioner-led clinic, which has really taken off in many areas. Alba probably can add more to it than that, but
Well, just the important thing to keep in mind is that it is not an N. The name is an unfortunate one. It should never be called an NP clinic. It is just a different form of a family health team. And the only thing that's different, really, is that the ratio of NPs to physicians is reversed. So in family health teams, you have many physicians and fewer NPs. In an NP-led clinic, it's still a multidisciplinary team with all the members that you would see, but the ratio of NPs to physicians is reversed. So there are more NPs and fewer physicians. And the reason for that is that the physicians don't exist in the community. So one of the criteria, for example, in Sudbury, there were 35,000 people without a family practitioner. No family doctors that were interested in going there. People were going to the emergency department. So the doctors that they tend to attract to work with are usually young females who have young families who don't want their own family practice right now, and so they work part-time with the nurse practitioner clinic. There's usually a physician there almost all the time, but they may be two physicians working 2.5 days. And so, so the NPs see any patient that falls within their scope of practice along with the team, but as soon as the patient falls outside of the NP scope of practice, they get referred to the physician who's part of the team.
the rostering mechanism is different too with the NP-led clinic.
That's right. I think it's an advantage that the patients get rostered to the clinic rather than to the physician. And so when the physician retires or moves, the patient still has a home with the nurse practitioner-led clinic.
So what about the billing then for those patients? They be seen by the nurse practitioners. The nurse practitioners are not allowed to bill.
That's right. That's right.
So-
There's a budget that keeps that NP-led clinic.
Because it's
so-
rostered.
They're rostered.
Yeah. Yeah.
Are there any other questions from the audience? No? Alright, so thank you everyone for the questions and for being in attendance here tonight for the dialogue. We hope that all of you have learned more about each profession and that clarity was brought to both roles. So on behalf of the McMaster Medicine and Health Society, I would like to thank Nancy, John, Eric, and Ruth for participating in this dialogue and on this panel. And as a token of our appreciation, we have prepared just a little something for you all. So, thank you very much.
Thank you.
Thank you very much.
Thank you very much.
Alright, and thanks very much once again for coming.